Hi, welcome everyone. My name is Nimra and I'm a part of the Partners Innovation licensing team. Welcome to this Discovery Cafe session on AI and its impact on the future of emergency care. We're really pleased to have such a record turnout at this forum. Part of my job is to just make sure that we keep things running on time. We have 75 minutes for the session today, including Q&A. And I'm really pleased to introduce our moderator, Adam Landman, who is the VP and Chief Information Officer at Brigham Health. He's also an associate professor at Harvard Medical School and an attending physician within the emergency department at Brigham and Women's Hospital. So I'll let Adam take it away.
Nimra, thanks so much for the nice introduction, and thank you all for joining us this afternoon. A couple of more thank yous. First, I want to thank Dr. Peter Chai, Drs. Alistair Martin and Shuhan Hay for their original idea of this panel and spending time really talking about how AI and other digital technologies will transform emergency care delivery. I also want to thank Chris Coburn, our Chief Innovation Officer, as well as Drs. Michael Van Rooyen and David Brown, the Chiefs of Emergency Medicine at the Brigham and MGH respectively, for their support of this panel. Just to set context, and as everyone's eating, kind of get everybody ready for this, I want to give a little bit of background. There are currently 135 million emergency department visits across the United States, and those happen in over 5,200 emergency departments. One of the most common reasons for visiting the emergency department is a skin rash. So think about yourselves. Think that just put yourself in this situation. It's Sunday night, last night, and you have a rash. It's red, and it's warm, and it's painful, and it's new, and you're really worried about this. So what do? Well, it's late at night on a Sunday or in the evening. You decide to go to the emergency room. You drive yourself there, and as you get to the emergency room, you are greeted, checked in, where they take your demographics, get you registered in the system, and then you're seen by the triage nurse. And the triage nurse asks you a little bit about why you're there, which you explain, and check some vital signs. And the triage nurse will enter that information into the electronic health record system. Well, the good news is that you're stable. The bad news is that the emergency department is pretty busy. It's in the evening on a Sunday, and you're a stable patient, and so you get sent to sit in the waiting room. And so after about 2 hours, you get in the waiting room, you get called back into the treatment area, and there your nurse that'll be taking care of you does another quick assessment, and shortly thereafter, the emergency physician comes to see you. And the emergency physician asks you about your issue, examines you, and ultimately diagnoses you with a skin infection, cellulitis. And the emergency physician feels that it's stable and can be treated with some antibiotics. They give you some oral antibiotics while you're in the emergency room. Then the emergency physician kind of goes off to their work area, does their paperwork on the computer, documenting the encounter, prepares discharge instructions, and writes a prescription for antibiotics for you to take at home. And then you are discharged. You are given paperwork that outline these instructions, and you're given a paper prescription for antibiotics to fill. Total time, 4 hours from your time you showed up to the time that you got sent home from the emergency department. So I hope that you'll take sort of three things away from this little vignette that we started with. First, we provide outstanding evidence-based care in our emergency departments throughout the country every day. But at the same time, our emergency departments are incredibly busy, and some patients can wait a considerable amount of time, 4 hours for something that was pretty straightforward to take care of. The final piece that I hope you'll take away from this is there's very little technology involved in what I just described except for the electronic health record. Everything is manual, and frankly, for at least the number of years that I've been involved in emergency medicine, the process has been exactly the same. Again, with the exception that we now do our data entry into the computer compared to doing the data entry on paper, which we used to do. And so in this panel, we're really going to explore how digital technology, including AI, voice assistant technology, mobile apps, has the potential to transform emergency care delivery. And we're really fortunate to have a really talented expert panel here to guide this discussion. And now I want to ask each of the panelists to briefly introduce themselves. Sean?
Sure. So my name is Sean Kelly. I'm not the talented part of the panel. That will be coming next. So I'm more the practical side of the equation. I'm a practicing ER doctor here in Boston. I'm also the Chief Medical Officer at Imprivata. In that role, I really look at workflows, specifically with regard to the digital workflows. As Adam just described, a lot of what we do in medicine is interact with the digital realm to better care for our patients. And exactly how we do that really makes a big difference on the outcome of that care, patient satisfaction, and provider satisfaction. I'm on the customer advisory board for an analytics company, Om1, does a lot of real world outcomes work and looking at indexing patients, understanding their risks, and then making that analytics actually actionable. So I think that a big part of what we wanted to talk about today is not just what cool AI tools might be out there, but how do you realistically use them in the everyday world and practically to address issues that we face every day?
Good morning, I'm Bijoy Segar. So I'm the odd person out. I'm the non-physician in the panel. So I bring an industry perspective. I'm the Chief Digital and Technology Officer for Stryker. And what we are thinking about is how do we actually look at clinical protocols in the acute setting, and how do we scale it, not in the best hospital, but also in community hospitals, all the other clinical settings, including ambulatory care centers and other places. But secondly, it is how do we actually take best practices from one hospital and help scale that across and learn from that using digital tools and other mobile-based solutions. Thirdly, there's a lot of studies that are showing that protocols actually work. But how do you convince everybody, especially over a long period of time, and this is not just the physician community, but also the supporting team communities in the ambulances, nurses, and others, to follow a specific protocol based on data that is coming through an outcome. So that's what we are working on, and really excited to be here to share our story.
So I'm Emily Hayden. I'm an emergency medicine attending at Mass General, and I'm also the director of telemedicine for our department there. I really am interested in looking at using telecommunication technology to figure out how to get the right patient at the right place at the right time. And I think that emergency medicine has a lot they can be doing with this. And so I also chair the interest group and the consensus conference next year for Society for Academic Emergency Medicine on telehealth and emergency medicine, how telehealth is going to impact our field and how we will shape telemedicine from an emergency medicine side. So.
I'm Peter Chai. I am an emergency medicine physician and a medical toxicologist at Brigham and Women's Hospital. And I'm primarily practicing clinical emergency physician, but also a researcher interested in how we build sensor packages to really change the paradigm of what we can discover and learn about patients, and change, the way that emergency care starts. So instead of starting in the ambulance or in the ED, why can't we look at emergency care at the point at when things start, so at somebody's house, and looking at the pre and post discharge planning.
Hello, I'm Kohei Hasegawa, one of the researchers and ER docs at MGH. I spend 90% of my time on research using millions of patients' data, including thousands of predictors and variables, including genomic. And this is much beyond human capacity, and we use machine learning approaches every day. And recently we have applied these approaches to clinical problems such as ED triage, prediction of patient scores. So I'm looking forward to the discussion today.
Great, thanks. As you can see, we have wide perspectives here, which was intentional to help organize the discussion. We're going to actually divide it up into three components that correspond to three distinct time periods within the patient journey within the emergency department. The first is arrival. So this considers what the patient would consider before they get to the emergency department. The The second time period is in the ED, so from the triage to their care within the ED, and the final component is discharge, so when the patient gets discharged from the ED to the subsequent care that they receive. So we'll break the discussion into those three components. And one other just housekeeping note, have folks downloaded the app for today? Raise of hands, the folks that have the app. Great. Okay, many do. Please note that you can submit questions through the app, and so please feel free to go in there. I have a tablet and we'll receive those questions and we'll try to ask those. For those that don't have an app, we'll also try to save a few minutes for questions either throughout or at the end. So as we get started, we're going to start with arrival. And if you think back to the case the vignette that I started the session with, the patient that had a rash and was concerned and went to the ED, one initial question is, what other resources did the patient have? Like, should the patient have come to the ED? Or are there potentially other approaches? And in particular, are there any patient-facing artificial intelligence-powered tools that patients might be able to take advantage of when they're thinking about the decision of whether or not to come to the ED? So I want to open it up with an open question if anyone wants to respond to that. Anyone? Go ahead, Emily.
At least from the, maybe not as much from the AI side, but for at least the telehealth side, that if a patient's sitting there trying to decide, I'm at home by myself, I have this rash, do I need to find, my partner's out of town, I need to find someone to watch the kids. Do I go to the ER now? Do I wait till tomorrow morning? What do we usually do? You could try to call the primary care office, but just like in the presentation earlier today, you're gonna have to go through that whole tree system on the phone, pressing the buttons and waiting for a call back. You can go to Dr. Google, which a lot of people do, and try to figure out, do you need to go in? What is this rash? And then the other piece that's coming up now from the telehealth side is these app-based virtual visits. So these are the American Well, Teladoc, are some of the companies, and then a lot of us use those companies to power our own virtual visits. So our partners Healthcare on Demand is powered by one of them. And so this is, it's not coming all the way into the emergency department. You don't have a set of vitals right there. You don't have a set of vitals right there from the nurse right in front of you when you start talking to the patient, but you have a patient on the video screen, and you can try to go through a physical exam as much as you can to be able to help that patient say, you know what, we can take care of this right now. It's cellulitis. You can stay there. I'm going to transmit the prescription for your Keflex to the pharmacy right now. Or you know what, that actually is sort of worrisome. You need to come in to an ER now or your primary care in the morning. So it's not AI driven yet. I think it definitely will be. But we do have things out there already existing where patients can go and make a decision if they have to come to the emergency department or not on the telehealth side.
Great, thanks for sharing that, Emily. And I know you're actively one of the telehealth providers. Can you share any of your early experiences with that platform or any feedback you've gotten from the patients that have been using it?
Yeah, I think that we've heard a lot of great things from the patients. I think they were surprised that they could go ahead and just within 15 minutes have an answer, that they can go online, log on, put in their information, and have a live physician or a nurse practitioner or PA take care of them and take care of whatever they thought they had to go sit for 4 hours in the emergency department for. So patients have loved it. Lessons learned, both patients and providers are still learning how to do this. So it's still a little bit clunky on trying to understand how does this work on both sides. So it's sometimes a little bit of an awkward dance between the provider and the patient. It's FaceTime to the nth degree in a way with someone you don't know. And so it's been great. We've heard great stuff. And we're trying to figure out how can we start doing more than just rashes? How can we start seeing abdominal pain on this? What about chest pain? And when we start bringing in all the information we can grab from Apple Watches and all the different things of electronic stethoscopes, there's going to be more and more that we're going to be taking care of using telehealth than just a rash. So the experience has been great so far. It's been interesting. Some patients have called when they've been driving, and we ask them, you should probably be at home or your office. You probably shouldn't be driving. They're like, no, someone else is driving. I'm like, no, I really think you're driving right now. So
You can diagnose them with the MVC coming up.
yes, I can. Yeah. So.
And I'll back that up too. I think one of my pet peeves is that a lot of these systems that are patient-facing that the patients might have access to might not have access to their own medical records in the EHR or the health system. So I really like it when healthcare systems interact and use and leverage third-party systems like Amwell or Teladoc or whatever it is, or just try to coordinate their own. I feel like Jimi Hendrix is in the room with us today. And that's really again, I'm gonna keep pushing on some of the practicality of a lot of these systems. And AI and machine learning is really valuable if it lives within a third party that is able to look at someone's symptoms. That's great, but if I'm a patient putting in some symptoms and I just forget to put in an allergy that I have, and that information is actually existing in the EHR, that physician may or may not know that. There's a blind spot for that AI, for the machine learning, for any system, really. So some basics around, we're emergency medicine folks, right? So ABCs, airway, breathing, circulation. We really pound on the basics. Interoperability between data systems is a huge plus to these systems and a huge negative if it's not there. So just having that data be able to crosstalk, even at a minimal standpoint, can really help, whether it's a consumer-facing symptom checker or whether it's a system run by the hospital looking at data that's coming from another third-party system.
So I'll probably give a technology background on this as well. As wearables are getting better and better every year, the idea is that you have to then look at how do you take the hype out and convert sensor data into something you can interpret consistently. I think we are getting there. So the unfortunate part of this cycle is the first couple of rounds it will be overhyping, right? Then a couple of cycles it'll be no, it's not working, and then we will get to that point. So FDA is now spending a lot of time talking about are these things wearable medical devices or not, and there's a lot of perspectives, and hopefully in the next year or so we'll get a more consensus view. And if that data can get into these systems and EHR, then you actually eliminate the need to have that physical examination to a large degree. It may not eliminate everything. So in China, when I was there recently, they're taking a lot more pragmatic approach in taking pictures, for example, with their mobile phones and sending it to WeChat so physicians can see it. So there's a lot of that kind of different approaches, which I think is really encouraging. But the thing that I worry about most is how do we get past this hype cycle and start making it more standard.
So I just want to share an audience question that I think nicely synthesizes where this is heading. And Sean, you're mentioning interoperability of the data and making that available. Bijoy's mentioning sensors or providing additional capabilities at home or in other settings for the clinicians to be able to access. So the question is around, do we have all of the necessary pieces to solve the major problems of the wrong patients presented at the wrong place at the wrong time? So in other words, are we truly able to help patients triage and get to the most appropriate place? You're mentioning we need to make sure we have the past medical history. We might need more than just video. We might need sensors. Are there other things that we need to make this sort of dream state a possibility?
Yes. It's obviously a really difficult problem. One thing that fascinates me is it's really a continuum of care. And you can actually look right now with AI and look at a whole patient population and predict. One of the outcomes you can predict very effectively is who's going to present to the ER or to a hospital or be readmitted for CHF or have a complication of a prior admission. And remember, we're talking about one point in time in this patient's care experience. And it may be just a simple rash that someone got in isolation of other medical problems. But more commonly, the real cost to healthcare, the real morbidity, mortality, there's a lot of it is a group of patients that are recidivists. They're in and out of the hospital, they're in and out of healthcare. And you can actually look at that right now with existing tools, analyze that whole population and say in a very granular fashion, look, the risk index here, here, and here is very high. And not only that, but you can actually dig in a more granular fashion and say, well, here are the reasons those people might present. Some of them are medical, some of them are non-medical. Some of them are geographical, social determinants. And so there's obviously a huge amount of variables here. Usually it comes down to the operations and the communications, not necessarily the technology. The technology is there in bits and pieces. It doesn't always crosstalk, and managing the human factors can be enormously difficult.
And the other piece is regulatory as well, which is how do you actually balance out the patient privacy with the need to share data? Because if you don't have a lot of data, the thing that I worry about machine learning and AI is if you don't have a lot of data, you can't really train the algorithm well. And to do that, you have to share a lot of that anonymized data. And we are still evolving that fine line on where is the patient privacy line and where is a sharing line. And I think that would be very helpful.
The other piece from a regulatory standpoint that I just wish we could get is just standards, because that data, there are different data sets, ICD-9, ICD-10, ICD whatever's next, SNOMED, just the staggering number of terms, and the fact that a lot of what we do in our documentation really is optimized for billing and compliance, not necessarily for patient care. And CHF may be called acute systolic failure, may be called, ICD code this, subset this, first time acute. And normalizing all that data and actually making it actionable and useful can be very difficult across different systems, across different vendors. So from a regulatory standpoint, standardization, forcing that could be really helpful for us.
In addition to that, the lots of data are unstructured. The machine learning AI, as a researcher, works very well with structured data with good label, including ICD-9, which is okay, but works good for stroke, MI. But lots of data, like treasure box in EHR, is unstructured text data. So deriving information, useful information, is difficult, but tools are there, including NLP, and abstracting meaningful information by building good algorithms. Go ahead, sorry.
So I guess the question is, are we there yet? And I think from what we're hearing is we're almost there, right? I think there's been a huge explosion in sensors and wearable devices. And I think the question now is, how do we put all these pieces together? How do we build that AI algorithm that can draw from a lot of disparate sensors? And I think that's where the innovation needs to be. I mean, we'll get better and better at building better sensors and getting better data. But how do you present that data to a physician who is not trained in machine learning algorithms? Like we need the data to be presented like a chemistry that is universal for physicians. And then allows us to act on that data. So this kind of digital health data that's coming out, we need a way to kind of present that to physicians and clinicians in a way that's actually actionable.
And another issue with the sensors, signal to noise ratio. So part of the equation is the AI can be as smart as the AI can be. If it's not in a usable fashion when it hits the end user, it can actually be dangerous, because you get this, you get barraged with data and you get alert fatigue, which we know that happens to us without AI. With AI, hopefully you can sift and sort that better and say, hey, of all that data coming in, there's the glucose of 42, right? Here's the heart rate of 162 that was not artifact. And that's where AI could really play a role, because it can do a lot more to sort that ahead of time. And I think that would be an enormous help to us.
I want to ask one specific question as we sort of finish this first section around arrival, and think about pre-hospital care, so ambulances. And think about, Bijoy, we were talking earlier about how to improve just the sharing of information between ambulances and hospitals. And sort of where do you think the future of that is, and particularly in light of new technologies like 5G that will really allow us to send a lot of information very quickly remotely?
I mean, that's a great question. This summer, we actually housed a few MIT students in a glass cube here in Boston. We gave them the topic of reimagining the ambulance of the future. And basically, they were in this glass cube for 3 days, and we didn't place any sort of restrictions on what they could think, and they came back and presented these views. So number one, how do we actually move ambulances from a transportation device, which is how it has been for a very long time, to a diagnostic device, which is where I think we are going, to actually a caregiving extension of the hospital, which is, I think, where we should go. And that's, I think, where these technologies are going to really come handy. So number one, with 5G, this is going to, if you do this correctly, it's going to be a revolution. Because what it does is it gives the capability of sending large volume of data from the ambulance and stream it to the physicians and other caregivers real time, so they can start treating this patient already in the ambulance. And that, with telemedicine and with everything else around it, this solves that problem of having to wait for the patient to arrive in a primary care setting before care is given. The second piece is, as we talked about, the false data and false positives. How do you convert AI analysis in situ? Meaning it doesn't really help a lot of times if The data is sent somewhere else, and they do all the crunching there, and then it takes forever to come back to a real-time setting in the ambulance. So how do you actually give specific predictors in the ambulance in real time so they can do something? So one of the things that we talked to EMTs, and they were talking about cognitive bias. So let's say it's Friday afternoon or Friday evening. They saw 7 drunk people coming through in the ambulance, and the 8th person is coming in, slurred speech, they are looking really tired, they have cognitive deficiencies, and you might think it's another 8th drunk person. And that happens more often than we think, right? So this kind of stuff can be avoided. Cleveland Clinic did a study, and they saw that in STEMI episode, before they applied an AI-based protocol enforcement, the gender bias in survival was about 6-point difference between men and women. It's not because of anything else other than how they were applying protocols and many other things. So we can use these technologies to eliminate that, move the point of care faster into the ambulance. And wherever we have seen those pilots happen, we have seen great results in outcome and savings of money as well.
Great. Thanks for that important perspective. I want to shift now to the second component of the ED care, which is in the emergency department, and start off probably the first place most patients encounter in the ED, and that's triage. And I want to specifically, Kohei, ask you to describe how you think machine learning algorithms can be used in the ED, specifically around triage, and maybe share some examples of the work that you're doing.
Yeah, so I'm going to set up the background a little bit, going back to the patient with rash. So I saw a patient years ago. I was working at the triage. I saw a patient, young guy, 20 or 30s, presented to ED with a chief complaint of rash and pain on the left arm. And heart rate was 120, but the patient looks young, nice looking guy, and he was just triaged to the fast track, waiting for 1 hour to see us. And then, of course, the patient has necrotizing soft tissue infection, and that requires emergent attention, antibiotics, and surgery to prevent losing his arm. So this is one of the examples that ED triage, how important ED triage is. That can affect ED costs, how to use the resource, finite resource in the ED. So going back to my research, so last year we have published several studies, including the work by one of the fellows over there. So we applied machine learning approaches to the nationally representative data of ED visits, about 20K patients, and by using routinely available data such as demographics, vital signs, chief complaints, mobile information, and ambulance. And we fit the machine learning models to predict patient severity, mortality, ICU admission. And they outperformed the conventional models, which is emergency severity index. And that is known to be highly variable, subjective, and it's okay. And another study we are working on right now, it's under review, is predicting severity in infants with bronchiolitis, which is the leading cause of hospitalizations. It's hard to predict what is going to happen in these infant babies. And the studies have shown repeatedly that the care is highly variable across the nation because doctors don't know what to do. And again, the fitting machine learning models using the data outperformed the conventional models. The punchline is that the doctors and ED doctors use 2 decision approaches. And A is like a fast heuristics and mental shortcuts, bypassing any analytic process. And this is like a doctoral patterns, which is good, but this is similar to chess players, dermatologists, radiologists, and pathologists. Another part is like more slow analytic process. We use very deep reasoning and causal inference using Bayesian schemes in your brain. It's amazing. But the first part, the fast part, can be replaced easily by AI. And this is going to allow us to make better decision making. That's the punchline.
Just one quick question before others react. I'm hearing reports of people having trouble hearing. Were folks in the back able to hear Kohei or no? Okay. So what I think we're going to try is, since we're emergency physicians, can we first, people can move up. We do have plenty of seats up here. That's one option. Another is, I think what we'll do is rotate this mic. It will take a few extra seconds to rotate. Can you guys switch off your mics, and we'll just, since this one seems to be working, we will try that. Sorry for the change, but hopefully this will help with the feedback and the volume. Thanks for sharing the great work that you're doing, Kohei. Did anyone have comments or reactions to the machine learning that Kohei's doing research on? Yeah.
Maybe to add a layer onto that, one of the things with Triage is it's a single snapshot in time, and so as someone who's triaging patients, you really get that snapshot of vital signs, that chief complaint, which allows you to kind of decide where in the queue a patient would go. And so one of the things that we're thinking about at Brigham is how do we change triage from a static process to a dynamic process? So integrating sensors into a waiting room that with infrared cameras that can allow you to look at changes in heart rate, changes in temperature, really changes. The thought is why people are coming to the emergency department to sit and wait, right? Like, emergency care should really start wherever they are. And, we're busy, but there are, I think, new sensor packages or even existing technologies we can use to really change that process and think about, how do we influence the way that we think about our patients? How can we, start their care a little bit sooner so that 4-hour wait becomes 3 hours, or it becomes 4 hours that were necessary, and allows us to do our acute interventions sooner.
Sorry, we now have to do this awkward dance with the microphone. Peter, can you elaborate a little bit more on some of the other novel uses of sensors that you're starting to work on?
Sorry about the microphone pass. So in terms of sensor data, I think a lot of the problems that we have in emergency medicine is that we do a lot of admissions or observations because we just don't know, right? We can't predict the future, and maybe we're getting a little bit better at that, but we don't know what's going to happen. So a lot of people are admitted or they go into observation care because of these reasons. But we have sensors that can help us do the exact same thing that we do in observation care or in some inpatient situations at home. And so, there are home hospital programs. We have one, and there's some very highly successful ones across the country. But integrating these new sensors, whether they're wearable sensors that allow us to look at changes in vital signs, but then thinking a little bit outside of traditional emergency care. So, what do we do about things like medication adherence, about fall detection or activity at home? How can we leverage the existing technologies that patients have, like smartphones, wireless bands of data that are kind of bouncing off of our bodies through cell phones? We can collect this kind of data and really start to look at how we can do all the care we did in the hospital at home. It makes patients more comfortable, but it changes really the paradigm of emergency care as well. So I think there's a lot to be said about picking the right sensor groups, looking at how you can integrate these into various parts of the hospital, and I'm hoping our goal is that emergency care spreads beyond our emergency department. It becomes into your house, and we care for you a little bit beyond that kind of acute time.
So I'll give a slightly different perspective, and this is the community hospital perspective. So nearest certified stroke center to Montana is Denver, Colorado. So unless you use these technologies, unless you look at sensors, by the time they get to the emergency care, you've already wasted a lot of time, right? So, but it's not just enough to put sensors in. Sensors are becoming really cheap, and you can design sensors in all kinds of ways. But the sensor data is completely unusable unless you convert this to scales that people can understand. And that's going to take a long time. So Jeffrey Moore's book, Closing the Chasm, I don't know if you've read it. The problem is a lot of the early adopters in more cutting edge centers of care, they're willing to put up with that noise. They're willing to try this because it's furthering the cause of the medical care. But if you go to the community care centers, they may not have the time or the budget to do that. So the next step is how do we take these sensors, create very simple to read, that chemistry example that you were giving, and make it more universally adoptable. So in the emergency room, they don't have to necessarily even think about interpreting. They can just look at it and make a decision. I think that's going to be the big challenge for the next, let's say, 18 months to 24 months.
Building on those comments on sensors, there's a question from the audience around consumer devices, and in particular, such as the latest Apple Watch that can record ECG tracings. First, are you starting to see this in your clinical practice of patients showing ECG tracings or showing up to the emergency room because their watch asked them to or told them to? And then secondly, and this sort of gets to some of builds on Bijoy's comments, what's the reliability of that data and the validity of that data, and have you starting to use it in your practice?
I'll comment briefly and then pass it along. I think absolutely we're seeing it. We're seeing an awareness of it. We're seeing an actual use of it. I used to run a home health business, and we leveraged a lot of technology, and even years ago used the iCore, which is a device, and before the Apple Watch was even as prevalent as it is now, to look at someone who we thought was in AFib and really wasn't. And he took readings 3 times a day for a couple of weeks, and he got to go off blood thinners and continue biking around. He used to bike like 15 miles a day, and we were worried he was going to fall and get a trauma. And he was sort of on the edge as far as needing anticoagulation. We're able to prove that just by sensors that he wore. And this was sort of early days. We're seeing it more and more. And again, I think the shame of it is that what we're seeing is anecdotal. It might be patient-driven, whether they bring it to our attention. Some places are looking at it the other way. They're saying, look, we have a patient population we need to monitor, whether it's around, and you start with the outcomes and work backwards. It may be a CHF population. It may be a diabetes population, a diabetic population. Those are 2 of the most common around these bundles, right? Advanced bundle care improvement. And working backwards from the outcomes, many places have decided that they're going to have case managers just distribute third-party apps to, whether it's through an Apple Watch or a home glucometer, and start taking that data. Right now, we see there's a lot of kind of patchwork. It's cobbled together. It's not stitched directly into the workflow. And you know what? It's still working. So I'm really looking forward to the near future when we continue to build those pieces into our armamentarium. Again, it's all about what's important and making sure we don't overload everyone with more data they're supposed to review during a visit that they're already overbooked for. So there's a human element, there's an operations element, but absolutely we're seeing this data starting to have effect.
And to just build off that too, I think we're seeing a lot from, there's so many innovations happening in our hospital system that patients are coming in giving us data that we have no idea what it even means, what it's supposed to be, and it's really great within that department of cardiology or endocrinology, but we may not know from emergency medicine, but we're going to be expected to know. So I think that's one of the barriers, or one of the things we need to watch out for, is to make sure there's that communication happening between all the different sort of siloed groups doing great work, so that we can still care for the patients the way that they're hoping that we will when we get that piece of data from whatever device is there. So something to definitely keep in mind when we're doing this.
I agree. We're definitely seeing an explosion of sensor data. But then, what do I do with, 3 days of heart rates from an Apple Watch in the emergency department? I don't know. And so I think it goes back to the comment earlier from the panel about standards. So, we need standards. Their sensors are cheap and they're off the shelf, but medically, what do they mean? And I think that's a lot as a researcher of the question that we want to answer is, is the Apple Watch good enough, or is it another sensor that's needed?
I just agree. I echo the importance of standardization. As a researcher, it is actually easy to develop models. if you have good data integrated into one system, EHR from hundreds of companies with different sensors. It's impossible for asking each clinician to interpret hundreds of sensors. So we need good integration of the data, and for researchers, then it's very easy to derive good prediction models or other models.
I'll make a comment as the microphone comes by. One important thing to keep in mind is just patient identification and security and privacy. I do not want that to get in the way of technology advancing, but we misidentified 10% plus of our patients right now using standard systems, never mind if we've got third-party apps coming in. And so your Apple Watch data might be helpful to me as a physician in your record, but it's not only not helpful if it's her Apple Watch data, but actually may be harmful. And so there are a host of complications there. So I would back up to the basics and say part of the reason that a lot of healthcare systems don't want to accept third-party apps unless it's really been vetted and standardized are for those two reasons. Accuracy of the data, because you pollute that system and suddenly your AI, it's brilliantly wrong because you fed it the bad data, or you're in violation of HIPAA and other compliance issues.
Building on this and maybe drawing from some of our lessons, and Sean, maybe some of your expertise in technology implementation, I think we've learned a lot with EHRs and are unfortunately seeing some of the unintended consequences of how electronic health records are now creating an additional administrative burden, leading to burnout in our providers. And I think there is some fear, the way, at least for me, I'm seeing another cycle coming with AI, everyone wanting to develop new algorithms and alerts for the clinicians and more information for the clinicians with sensors. So how do we get ahead of this and learn from our previous experiences and start thinking about workflow and usability now, before, when we're in its infancy and can do this better than we did before?
I'll go first. I have strong opinions. I'm sure we'll get this wrong, but not for lack of trying. I think we need to start with outcomes. What are the outcomes that matter most? What are the problems we're trying to solve now? What's killing patients now? What is losing us money now? We know what a lot of those things are, and then we need to map our technology to those problems, not try to get cool technology and push it into a system in random places, right? So in many ways, this is going on. So I mentioned bundled payments before. That's one way you can look at a set of data and say, look, we know of all these adverse outcomes. We actually know of some positive outcomes too. If you look at that and then you work backwards and say, well, there's a lot of existing AI systems right now, and Peter, you had mentioned that we can't predict the future. The scary part to me, and I'm not the uber technologist, I just deal with the results of a lot of this and try to put it into workflows in a way that works. The scary part to me is we're getting pretty close to being able to predict the future. And when you look at a lot of these AI and machine learning models, right now we can look at everyone in this room and a whole patient population and say, these people are going to pop out and they're going to have an adverse outcome in these 3 or 4 areas. And not only that, but we can actually in a granular fashion look at why that might happen. And what that tells me is we could actually then act on that. And that last piece is actually really hard because, you know, as others have noted, and Adam said, don't give me just another system that I need our doctor to go look at off to the side. Because in the heat of battle, I don't have time to do that in the ER. But if you can run that in the background, you can pick off from an administrative standpoint, a leadership standpoint, and a clinical operations standpoint, what outcomes really matter. And some of them have been mentioned. Is this person going to be triaged and admitted to the ICU? Are they going to have a negative outcome? Are they going to have neck fash? Are they going to have whatever those outcomes are? If that can be alerted, real-time decision support in my system where I'm working, and that's a key point, is it needs to be stitched into the EMR or somewhere else or layered in such a way that it's actually pops up, allows me to know I can actually act on it. So analytics are fine, right? Predictive analytics, being able to tell the future, that's really powerful. Prescriptive analytics, where I can not only tell the future and say, look, this person's going to fall out of that bundle. They're going to get a DVT after their joint replacement. Here's why. Here are the 3 factors you have control over right now, Sean. right? They went home without their Lovenox, start the Lovenox, right? They don't have PT started, start the PT, and one other thing, right? If it's actionable, it could be really interesting for us. And I mean, the bad news is that can be hard. The good news is there's so many interventions we can work on. Even if we pick off one or two, it's going to be really impactful.
So I have an opinion. In fact, I would love to get the other panelists' thoughts on this. Where I've seen AI work really well is in taking micro problems and trying to create answers out of it. Where AI doesn't work is if you try to solve macro problems. So one or two examples without naming the companies involved. For example, oncology prediction, with all the comorbidities and everything else, it's going to be a very difficult problem for an AI machine to go immediately say, this is the issue, just because you have 8 or 10 sets of data. You probably need 8,000 sets of data. So in many of these cases, I think where we are struggling in terms of scaling is how do you find those things, as you mentioned, which are actionable, outcome-based, and then focus on AI where it actually is going to create a value, whether it's diagnostically or clinically or economically. So 60% of CT scans don't necessarily aid in the diagnostics. You just don't know which 40%. You don't know which 40%. So you essentially have to do this right now defensively, right? You'll order the CT scan because that's what you do. But if you know it just in time, specifically, you probably could modify the behavior that would have an economic impact. So I really would love to get other people's thoughts as well on how do you think about this problem, which is doing this micro, testing it, and then creating solutions that are directly outcome-based rather than trying to solve a big ER situation in total.
Well, I think one of the answers is we can't solve the ER situation. And I think when I first started in this research career, we wanted to have sensors that would, change all of the problems in the emergency department, but I think you quickly realize that you can't. And part of the research in me is that it's important to know what your question is first, right? Like we don't want the new technology or the new sensor because it's just really cool. We want something that's going to really change the problem. So if you're looking at CHF, you want to look at a specific outcome, whether that's rehospitalization, whether that's non-adherence, whether that's something else. I think you want to kind of hone in on what your problem is and then apply something that will work. I mean, I think one of the biggest mistakes is going out and finding a sensor. It's really having the solution and picking out what is already existing and will work.
Microphone, I'll respond. I would start with the outcomes and work back, just as you said. And so, we have a pretty robust QA program, and you can just start with that. If there are any provider systems in the room, start with what your adverse outcomes are and work backwards. So, when we admit a patient to floor level and they go to the ICU within 24 hours, are there predictors of that, right? When we send someone home and they come back within 72 hours, are there predictors of that? Are there post-operative patients that get infected? Are there line infections in the hospital? And so some of this is ER-driven. Some of it is ER in the context of one waypoint in a patient's journey, either in or out of the ER as being discharged home or to some other facility or to the hospital. And someone had said earlier, wrong patient, wrong time, wrong place. And so if you think of that as your adverse outcomes, how do you prevent that? And you look at your existing patient population retrospectively, analyze it, and then those same patients moving forward, say, area under the curve over 90+%, saying, look, we can pick off this subset of the population is likely to fall out for these reasons. Then it's up to the hospital to decide what that intervention is. And the truth is, in order to really make this actionable now, it's not all technology. In fact, most of it is the process of managing the data on the front end. The AI part is usually, once you build the models, it crunches it quickly. That's the point. It's fast and smart. And then operationalizing it afterwards. What is the key punchline to say, look, we've decided CHF readmits are bad for many different reasons. How do you prevent that? Well, that's a different problem. It's not the AI. It may give us some insight into that, but really it's now how do you take that patient population and do something in an intervention to stop it.
The conversation's been excellent and really focused on appropriately patient outcomes and improving care delivery. I also want to shift to patient experience and employee experience, because we know that it's a demanding environment. As I mentioned, EHRs are contributing to administrative burden and burnout, and so are lots of other factors in care delivery. And technology can often also negatively contribute to that, but can also help. And so I'm curious if anyone wants to share ways in which digital technologies overall, and certainly AI, are being either used or thought of being used to improve the patient experience as well as the provider experience.
Yeah, just anecdotal. So one of my family member has been sick recently, and it's not MGH or Brigham, but I have been to the ED several times for the last month, and I noticed that I've been healthy. I haven't been to the ED for a while. And then the thing I noticed is that the doctors don't talk to the patient, don't see us anymore. They are looking at the computers, typing into the EHR. That is difficult. And I believe patients experience that the doctors don't care anymore. And this can be handled easily by AI using, basically we should remove the keyboards, right, from the ED. We can do natural language processing. Abstracting the conversation is a little bit difficult, but this is attainable. Then easily improve the patient satisfaction and communication. This is just one way, an example.
I'll start with lower hanging fruit. So at the Brigham, with Adam's support, one of the things that we looked at is in improving the patient experience and the staff experience regarding the cleanliness of the emergency department. And we used a very simple solution. We used an IoT button, and we basically placed them in our restrooms and allowed the public to really help us gauge the degree of cleanliness of our restrooms. And it's a cheap and simple thing that is just a button. You press it if it's dirty, and we trained our environmental service staff to do a double press when they cleaned it. And we've actually shown over the past year that our restrooms are cleaner, people are happier, we get less requests for cleaning. So it improves the patient experience, I think, and it gives them, they kind of help us understand the pulse of cleanliness of restrooms as kind of one aspect of the patient experience. And so I don't think all technology is bad and adding more burden to us as physicians. I mean, we've looked at other kind of potential interventions, I think we're building a new emergency department at Brigham, and the idea of what kind of technologies can improve and change the staff and the patient experience. Whether that's thinking of emergency departments as more than walls, right? There's sound, there's light, there's so many other different senses that we can really impact with new devices that can change the experience. And if someone's got to be there for 4 hours, we might as well make it as an enjoyable 4 hours as they can.
And then putting the telehealth hat on, the goal is let's try to keep these patients from waiting for 4 hours in our emergency department. So who are these patients that don't need to be in the emergency department, and that we can either care for them at home or in their office using the virtual-based applications. There's also different transfer coordination to try to keep patients who have had to be transferred from another hospital to from a busy hospital to another busy hospital waiting to be seen. Using telehealth to be able to try to really keep those patients at the right place, right time, right location. And so I think for the patient side, telehealth can really do a lot, hopefully. I mean, it can be also, they can wait a long time for a provider to come online too. However, they might be in their own environment rather than in our waiting rooms. On the provider side, really that sort of goal will be is that, it's hard doing some of those shifts, being in there, being in the harsh lighting. So can we have it where we have I have my shift in acute tomorrow, I have fast track the next day, then I have telehealth. So I actually take this from home, and I can be able to be at home, be able to work on other things until a phone call comes in. So to be able to try to, I think for emergency medicine, a lot of us would say we'd rather not have to have the exact same location assigned to us on the shift every time, because we like that difference. So to be able to have an extra spot, an extra location where we as providers can maybe be a little more relaxed and be able to provide care to patients at the same time would also be helpful for emergency medicine on the provider side. So.
So I have two perspectives on. One of that is voice-activated systems. So you're going to see more and more ORs, for example, that'll be voice-activated. You're going to see a lot more systems where that control is going to be voice-activated. And that's an easy problem to solve than actually taking dictation, because medical terms are really difficult to train these AI systems, especially in the context in which a physician uses it. And I did a pilot which very famously failed, and that was an AI-based chatbot. And the system could not recognize sarcasm, could not recognize contextual questions which were not formed as a question. All of these things that we don't even think about, in the medical setting, that could be a serious problem if you consistently get those things wrong. So that, I think, is going to be 5 years out. But the voice-enabled systems are going to be a lot sooner, and that's going to solve a lot of those problems that people are facing. I also think that emergency rooms are structured today not necessarily for the employees, but for the patients, right? The placements, the waiting room, all of that. So you could probably address with digital technologies better flow, better check-in and check-out processes, fatigue control, all kinds of things that is happening today, because it's not necessarily designed with the employees in mind. It's designed, and I'm not questioning the fact that obviously patient outcome is the most paramount thing. But the one industry that has gotten this right is airline industry. And I'm not saying everything is perfect in that world, but a lot of these things that we are talking about, how do you control fatigue of patients, pilots and other employees, they have been working at it a lot longer than in healthcare. And how do we use some of those technologies that they've developed and methods and apply that in this care? That'll be really helpful. Even in the VR-based training, for example, airlines have been doing this to train pilots for a very long time. We have not used it as consistently in the healthcare field, and we could probably do that to enable a better experience. So there could be other things that we could do. A lot of activity is happening today. So if you look at a lot of startups, none of this is a pipe dream. There are a lot of startups doing a lot of things in this area. I just looked at a hypnotic VR product where they want to use this in the emergency rooms for patients, for example. Of course, this is very early in the stage, and when you talk to startups, they really think this one solution is going to solve all problems, but it's going to solve that problem eventually. It may not be the way it looks today, so I'm very hopeful of this problem getting solved in the next few years.
Just want to reinforce the point around natural language processing. And I think one of the most difficult things we deal with as providers is just doing repetitive and duplicative tasks over and over again that seem mindless and really distract us from actually getting to work with our patients. And so I am old school. I do talk with our patients. And when I'm in that room, like that CHF patient, I might explain that, we think you have fluid in your lungs and we're going to start a diuretic and a vasodilator. Here's what we're going to do. We're going to check some blood work. I'll go through everything with them, and then I'll walk out and I'll talk to the nurse and have the same conversation in nurse-doctor speak. Hopefully I would have had the resident or the med student in the room with us so we could have that all together with the patient. But I might go through the same story again, and then I'll go sit down at a computer, and guess what? I'll order all the stuff I just talked about ordering. And then the most important part from all the billers and the payers, what all of our systems are actually optimized for, I'm going to sit down in the EHR and document everything so they can be properly billed. And that is madness for us, right? So to be able to actually do that once and have it maybe at least tee things up in one or two of those systems so we can look it over and approve, or even remind me, hey, Sean, the last 10 times you saw a CHF patient, you got a BNP and you forgot this time because you're a human being and you're tired. You spent too long talking to the patient like you do. So do you want to order that? Oh, yes, I do, or no, I don't in this case. So I think those getting rid of the stupid, mindless tasks is a great job for AI.
And there's a wonderful New England Journal article on exactly that topic if folks are interested. Building on your last comment, Sean, and I want to spend just a few minutes on the discharge process. Arguably, that is the most important part about the ED encounter. You've come for your urgent issue. We have a plan, and now we're trying to communicate it to the patient. And as you'll remember from my description, It is a very manual process, and as Sean described, very duplicative. You explain it verbally, possibly to the care team, then to the patient, then you go write it up, and then we hand a piece of paper to the patient. And I love people's thoughts on, are there opportunities to change that process or redesign that process going forward with digital or AI technologies?
I'll take it because I think like you, I think I'm recognizing a kindred soul. Whenever I work with a new student or resident, I'm like, look, every attending's got their quirks. One of my major weirdnesses is I obsess over discharge instructions because I think that's where we often fall short. So I'm saying, don't blow off discharge instructions on my watch. This is a big thing for me, and I actually sometimes let them not write notes and just do a good discharge instruction. So it's an area of interest for me. I have had many a patient go home with belly pain that we knew we didn't, right lower quadrant pain. We talked about risk and benefit of doing a CT scan. We didn't want to over-radiate. We thought maybe there could be a chance there could be a ovarian cyst or an appendicitis, and we went into that with that knowledge with the patient. They went home, came back the next day. It was a little worse and got a CT scan. It was all very appropriate. That same case, if we hadn't handled the discharge right, could be an absolute wreck. Can AI help us there? Absolutely. So where it gets really complicated is we always think of a single system. So, a head injury, alcohol, intoxication, confusion. The problem is people don't read the manual and come in for just one of those, right? They have like 5 or 6 things, and some of them can be mutually exclusive. Some of the discharge instructions you give for one may actually not be for the other. So they've had a stroke and they have a head injury, and normally they're on aspirin or Eliquis, and you want to stop one of those. And so you really need to be careful about these things. And so for anything other than just a very rote single system discharge, which I think we do okay with because we can manually select those, and even some of the AI we have now automatically selects, hey, the blood pressure's high on several readings. They don't carry a diagnosis of hypertension. They could be in distress, but we want them to follow up for this. Hey, there's a pulmonary nodule on the chest x-ray. We're going to include that in our discharge instructions. So we're automating a lot of this with AI. The room for improvement we have is, I think, on most of our cases now are complex. The aging population, comorbidities are increasing. Nobody's that simple anymore. And half of them now will get off to urgent care or telemedicine. So out of the ER, what we really need is the AI to look at the things that we didn't even really realize that for a discharge for this person, it's actually 3 or 4 things layered on each other. And here's the matrix of things that need to be concerning. And this is the proper discharge instructions you need. That's what I see the future for AI and discharge.
Great. Thanks for sharing those comments. And I'll cheat and add one comment, mainly because I'm so excited about it. Many of you may have read that Amazon has finally achieved HIPAA certification for its platform and is starting to offer Alexa skills to select organizations. I see this as a huge opportunity for discharge instructions in particular. Imagine if Alexa can follow up with your patient the next day, ask them how they're feeling, ask them if they're taking the medications, remind them of the instructions you just provided, or remind the caregivers of those instructions. So I think there are some low-hanging fruit that we can do on the simple and the complex patients to help with discharge instructions. In the last 10 minutes, I want to kind of go to a rapid fire session and really ask all of you for your quick thoughts in a minute or two on really what does the future of emergency care delivery look like? Will we even have an emergency department's physical structures in the future? And obviously for the audience, these are, we're just asking folks to opine on this.
Yes, we will. I think, as I said, the population's getting older, more complex. I think if we right place, right size, right time, everyone, we're still going to have the sickest of the sick that you really want to just do it all in person. You can most efficiently get it all done very quickly. I think the future of emergency care, certainly it's a borderless environment. It's a continuum of care. There'll be better communication with pre and post visit, but absolutely the ER will be, I think, still in the center of a lot of that.
Yeah, I think ER setting would continue to exist, but I would hope that some of that care would go into the ambulances, for example. And more importantly, I think ERs will become better integrated with the rest of the clinical setting, so that wall that exists in many hospitals would probably go away. But thirdly, I think there's a lot of this 911 control room-like setting could apply in the ER world. So I'm actually tracking a project that's going on right now where the catchment area is 400,000 people. They essentially put physicians into a 911-like control setting, and they're trying to provide care that way. So yes, eventually you cannot avoid that physical meeting, but to some degree, when you're calling that number, you're already getting somebody who is an expert ER physician intervening early on. So that might be another way this could evolve.
So I'm going to somewhat disagree a little bit about the emergency department of the future, because I don't think there's going to be much of one. I think that there might be a couple of rooms in a hospital or maybe a freestanding department. That would be for patients in cardiac arrest or major traumas. But I think that I do agree with the piece about a control room. I think there is going to be a part for emergency medicine providers to be more in the control room environment, using the sensors, using the telehealth. And so, when EMS has a patient and they have their tablet on board and they go ahead and contact into the control room, per se, we're able to do telehealth, we're able to use the sensors, and we can say, like, yes, that person sounds like, has pneumonia, they need to come in given the available data we have. You know what, I'm going to have you, just give me a second, you look on the bed board, okay, great, you're going to go to this bed. And the emergency medicine team is the initial team that will see you, but it's not in the emergency department, it's actually on the inpatient floor. And they can go up there, they can start any resuscitation needed up there, and then can all be communicated with the teams that'll be taking over, whether it be the surgical or in the internal medicine team. But I really do think we're going to be shrinking the actual footprint of the emergency department in the hospital, but yet seeing probably many more patients given all this information we're able to obtain from digital sensors, AI, and telehealth. So.
I think emergency rooms will continue to exist, but they'll change. And the emergency department may not be the emergency department you drive to. It may be your house. It may be the ambulance. It may be a drone that flies to you to deliver care and deliver medications. So I think our practice as emergency physicians won't change much, but the methods and the technologies we use to deliver care are going to change.
Yes, I agree. So emergency medicine is going to remain. But our job is going to change a little bit, like dermatologists, radiologists, pathologists. The job, what we do, a part of the job we do is pattern recognition. It's going to change. We're going to do more. We're going to help patients by giving information, teaching better, and assisting the transition to home care.
I want to ask just one final question. First, thanks for sharing the insightful comments. It's nice to see we sort of clustered together in how we view the future of emergency medicine, and we'll see if this comes to fruition. I suspect it may, given that we have many of the leaders of the movement here on this panel today. But one important question that was raised by the audience, what about patients and families that may not be able to afford some of this technology? And are we going to create a digital divide? Does it already exist? What are your thoughts so that we can ensure? I mean, one of the most incredible parts and reasons why I like practicing emergency medicine is we take care of everyone, no matter what. When they come to our door, they're our patients, and we embrace them and take care of them without regard to their ability to pay. So as we enter this new world where patients may not have all of these sensors and technology, how can we ensure that we can still provide that same level of care?
I'll start just because the microphone's making its way past again. I think it's actually the opposite, that we're sort of democratizing the availability of a lot of technology. Just our phones, what we look at now, what's available on most smartphones these days, the high power of processing, the sensors that are already being built in as far as biometrics, I think that's only going to continue. I think that just being able to get online and search, think of 10 years ago, like it just wasn't available to people. Now the power out there and the ability, a lot of even free apps that are out there. So I actually think it's the opposite effect, that it's more and more available, and gosh knows it's available, right? Dr. Google, everybody who comes in thinks they have cancer because they searched on Google, there's X, Y, or Z symptom. But that, again, we're at that stage of technology where, there's a craze, then it gets refined, and we're kind of going through the different peaks and valleys. But I think absolutely it's giving people the ability to go search for themselves and independently verify before they see the doctor, during and after they see the doctor. My people searching stuff in the room after I tell them the diagnose and say, oh, yeah, it really does look like what you said, doc. Thanks. The medical school is worth it.
So I have a complementary perspective. So number one, economics obviously matter. So today, one of the things that we are struggling with is how do you get paid for all of these new technologies, right? So there's a lag, and there's a discernible lag, and therefore a lot of the forward thinkers are using it even if there is no economic angle. But for this to scale and become universal, you have to have acceptance so that these things actually are recognized as clinically relevant and get paid for. And that's going to be a little bit of time. Secondly, then, these devices are getting cheaper and cheaper every year. The reason it's a problem now is because you're not going to pay $600 or $800 if this is a problem for you economically. But we'll get to a point where this is going to be something that you buy in the house like you buy a TV or a microwave. It's the diagnostic devices of the house is going to be part of your household furniture, if you will. And if you get to that point, and you might think that's going to be a long time away, it's not. Actually, when you look at the number of devices where these things are built in, this point of entry is going to get shorter and shorter. And I believe at some point when to cover the last 10 million, even if you give this as part of your care package, you would still be okay. So if you're a Medicaid patient, you can't afford it, it's part of your continuum of care. You actually get it, and it's a rental device. It's free for you, but it's good for everybody else. So I think that's how we're probably going to bridge this divide. But the most important thing is to convince the payers the clinical necessity for these devices and the data that is coming out of it. And everything that we talked about, which is standardization, interpretation, all of that we have to work on. So we don't have these false positives that would shift the pendulum in the back. And that is one worry I have.
As far as the divide, it's already happening for the telehealth. When they look at, for telehealth, we say we're trying to increase access to more people to healthcare. And when you look at some of these app-based programs, we're finding that it's actually those patients that actually are still closest to the hospital that have a higher socioeconomic status than many of the other patients that we're hoping to pull in on these programs. And so it's already happening. But for the economics, is that a bad thing or good thing? And right now, if they can go ahead and they're able to pay for this and be able to try to get to that point where things become much less expensive, then someone can say, that divide's going to happen, but it's okay right now. But we have to be very well aware of it. In emergency medicine, we see the whole gamut of patients. We've seen the poorest of the poor all the way up to the VIPs. And so I think it's on us to also make sure when we're trying to create these algorithms, create these devices or these programs that we're not forgetting all of our patients. And so how can we be doing this? I think those are questions we need to answer and we need to grapple with, because I don't want to see that we go all the way up here and yet the people that are the most vulnerable are completely left out of this. And it'll happen if we don't keep an eye on it. So.
Yeah, to echo everyone's points, we're at this point where we've talked a lot about social determinants of health and medicine, and now we're at digital determinants of health and these digital signatures that people will have. So I think in the U.S. it's definitely convincing our payers and our insurance structure to pay for these things. But there's examples of digital health technologies that are deployed across countries that have different types of insurance structures. And if you look at universal health care, I think there are opportunities to innovate and build the reasons and the use cases for integrating digital technologies into other different types of pay systems. I think it's a bigger question than a lot of us realize.
So nothing much to add, but I'm going to give you a little bit different perspective. So the AI currently is learning from us. The teacher is us, and the teacher is actually biased and stereotype, and the AI is learning from our behaviors, like chess players. But now, like AlphaGo, they are not learning from chess Go players anymore. They are learning from the game. So if we structure the algorithms better, we can mitigate this problem in the future.
And can I add one more thing just to give you a different perspective? So in Senegal, this is the other side of the medical practice, right? In Senegal, a startup company is now providing emergency care entirely using AI. And they are essentially delivering it using Nokia phones on text. Because there are no emergency physicians, so you're not replacing an emergency room and physicians and all of that stuff. You're essentially accessing people who have no care. So you have the village chief or what have you now texting to a number, and you're getting some level of care based on a certain number of parameters. So your point about the machine is really sort of driving it. We will never probably get there, but in the other side of that market where they have no access to healthcare, AI is already helping. Clearly, you cannot compare these two systems of care, but there is some hope in that side as well.
Well, we may begin to learn from these developing countries that don't have the infrastructure that we have, and they're sort of leaping forward. So we have lots to learn there. I want to thank you all for sharing your insightful perspectives. I know there were many more questions that we were unable to get to. The panel will try to stick around for a little bit if there are additional questions. Now I just want to thank everyone and give a round of applause for the incredible discussion.